Honor to call Dr. Shomu Bohra sir on stage and explain about ECG which make you alert. I would request the chairperson to introduce the esteemed speaker.
ECG alert, second.
Hello. I know all of you know Dr. Shomu Bohra, a consultant electrophysiologist, UN Mehta Institute of Cardiology and Research Center. He is visiting hospitals in Ahmedabad and Vadodara. He is the author of chapters in various books of ECG. I request Dr. Shomu Bohra to start.
A very good morning, the august audience. Thanks FPA to invite me here, especially Dr. Pragnesh for giving this ECG talk. Dr. Pragnesh has described that you need to be aware of basic things, get a good infrastructure. So let me put this way. How many of you have ECG machines in your clinic? How many of you don't have it? And why don't you have it? Is it the cost, or you don't know how to read so you don't want to do it? So again, updating your knowledge. Right now the ECG machines are available very easily. 15,000 rupees, you can just upload it on your mobile and you can get a 12-lead ECG. Spandan, various Indian companies bring up these ECG machines that can be used in the periphery also. You don't need good infrastructure. You just have to have this small thing. You need to apply the ECG. They will upload it onto your smartphone directly. And if required, they will also give you a report within some time. So that is one. Second is knowledge that you have. Means you have been practicing for so many years. And the patients have more faith in you than any of the specialists put together. Even when I say that you have to go a procedure, they will call, no, you ring up my family physician and let me know whether it is right or not. So I have to talk to a family physician, take his approval for doing any procedure. So the faith that you have is unparalleled. We are just passers-by for one procedure or otherwise. But what you do is something which is commendable. And thirdly is updating your knowledge, learning new things. So a basic framework of knowledge is very important in any situation, and recognizing these small things is very important. And all the investigations put together is based on some clinical criteria. So if the patient has chest pain and the ECG is normal, I will still refer the patient. If the patient has bradycardia, you don't understand anything and the ECG shows bradycardia, I'll still refer a patient. So clinical knowledge is the basis of any investigation. Investigation will help you to become alert when to refer immediately or when to refer late. That is what I am here for. So starting my talk on this basis, what are the cardiac conditions wherein you need immediate attention, be alert, and these are any patient who has chest pain and ECG suggestive of ischemia, any patient who has bradycardia, and patient has ECG suggestive of a heart rate which is less than 50 or 60. If a patient has palpitations, giddiness, and the heart rate is beyond 150, and there are some miscellaneous conditions which I will talk to. So what is ischemia? And this is the most common complaint that a patient comes with, chest pain. Chest pain which is central, which is a dull aching, a patient who says that it is crushing sometimes, increasing on walking, but typical features of an unstable angina would be chest pain at rest, sweating, nausea, vomiting. If you have this and you take a ECG, generally it will be abnormal if the patient has an MI. So the features of any ECG during ischemia will be infarction, ischemia, or injury. So ischemia will be represented by T-wave inversions, injury will be by ST elevation or depression, and infarction by abnormal Q waves. And I hope that you have seen these ECGs quite often. So we'll go one by one, and I'll keep it interactive. So this is a patient with chest pain who has come to you. What do you think? Is it a alerting ECG or a non-alerting ECG? And what is the alert? Due to? Excellent. So is it a acute anterior wall MI and an old anterior wall MI? So if a patient has ongoing chest pain, that means something is going on. If the patient did not have chest pain, then my mind goes somewhere else. So if a patient has ongoing chest pain, the first thing I'll think is this is an anterior wall MI. And you need to refer immediately. Why? Because there are no Q waves. So if you see the ECG, there is significant ST elevation, but no abnormal Q waves. So ST elevation is in the anterior leads, and that suggests anterior wall MI, large area of infarct, and therefore it is a high risk. So you need to be alert to send the patient immediately because it can be revascularized very easily. On the other hand, you have this patient. Now the ST elevation is not very high, but again there is no Q wave, but the ST elevation is in large area. 1 and AVL also ST elevation is there. So any ST elevation in a larger area means more leads, 1 AVL, anterior, all the leads, or ST elevation which is more. These are the two high risk features where you need to be alert to send the patients immediately to a interventional or a center wherein you can have modern facilities like IABP and angiography. On the other hand, this patient who has chest pain, but it was 12 hours before, 1 day before, now is settled nearly and has come in a patient to say that I had some chest pain, I'm okay now. So what to do? So you can see here that there are Q waves, abnormal Q waves which have come. The ST elevation is still persisting. So persistent ST elevation can still occur with ischemia, still you need to refer, but these are patients where infarct has already developed. Patient with no pain and is coming to you, definitely you can wait, but if you have an ST elevation persisting, you can still send the patient immediately. So still a patient requires a referral immediately. What about this ECG? When you find a patient who has a simple monophasic QRS complex, these are the highest risk patients. Highest risk patients, ongoing chest pain, send the patient immediately. So recognizing the high risk patients is very important. So anterior wall MI, ST elevation persisting, absence of Q waves, these are treatable immediately rather than sending otherwise. Coming on to this patient wherein the patient has chest pain, but you find what? You have ST elevation or not? So you have ST elevation in leads 2-3 AVF rather than the anterior leads, and these patients are inferior wall MI. Inferior wall MI have lower risk as compared to anterior wall MI. The ST elevation in inferior leads means a smaller area, that is a smaller area of infarction denotes lower risk as compared to anterior wall MI. So when we see this anterior region, it's quite large as compared to the inferior region, and that is where you should recognize ST elevation in anterior leads, 1 and AVL, higher risk, 2-3 AVF only, lower risk. Okay. A patient who presented with chest pain again, what do you think is the reason? Sorry? HCM patients, why should they have chest pain? So again I said clinical knowledge is very important. The first thing that you should understand is clinical knowledge. Clinical chest pain, you have deep T wave inversions which are symmetrical. HCM will have asymmetrical T wave inversions. Symmetrical T wave inversions, QT prolongation, all signs of ischemia. Again, chest pain with T wave inversions is high risk. Always think of ischemia rather than a LVH or electrolyte imbalance, which is also associated with these STT changes. Again, a patient with chest pain. Excellent. Why did you say that? ST depression. So ST elevation is high risk. ST depression is low risk conventionally, but if you have ST depression in most of the leads, you can see ST depression is there except in AVR and AVL where there is ST elevation. So if you have ST elevation in AVR and AVL, but ST depression in all other leads, these are very high risk, even higher risk than the ST elevation MIs, especially the anterior or inferior, because this denotes triple vessel disease or LMCA disease. So ST depression of more than 0.5 millimeters or multiple leads involved is high risk patient. So you need to be alert. Any patient with chest pain with ST depression also denotes high risk. Lastly, this patient with chest pain. Okay, so good. There are three differentials: early repolarization, pericarditis, and MI. So if you think that this patient doesn't have MI, now chest pain is there, but what kind of chest pain? Chest pain on inspiration, expiration. These are the classical features of pericarditis. So if you have that, think of pericarditis because ST elevation is there in all the leads. There's no reciprocal changes and there is PR elevation in AVR. So simple, and if you auscultate, there will be a pericardial rub. So clinical features and echo if you do, it will be normal. No RWMA. So ST elevation in multiple leads, but the patient is otherwise stable. Think of pericarditis also. So switching on to bradycardia, patient who presents with giddiness, patient who has exercise intolerance or breathlessness, there are only two causes of bradycardia, sick sinus syndrome or AV block. What is high risk? AV block or sick sinus? AV block. So you get a patient who has fatigue only. The patient comes to you with fatigue, patient is able to walk but gets fatigued. So you can see here the P waves are more than the QRS complexes, but the QRS complex is very regular. If your QRS complex is regular, P waves are lesser than QRS, basic fundamental, this is AV block. And this is a stable AV block. The patient is generally stable. You need to be alert, but the patient need not be referred immediately. Yes, the patient should be referred to a cardiac center for further evaluation. But however, if you get this kind of patients who are syncope, you can see here this is coming here, the PQRS is coming and suddenly there is only P wave, no QRS. Suddenly the QRS is gone. These are the patients who are at high risk of having syncope or sudden injury or sudden cardiac arrest. And these patients who have syncope associated with bradycardia are at high risk. So again, ECG feature of AV block with syncope is high risk. Okay, not only ECG features. So if a patient who has a history of syncope and has LBBB at baseline, you have an LBBB at baseline and history of syncope, think that intermittent AV block is going to happen in this patient. Rather than say nothing, you need an angiogram, they require an Holter. They require evaluation to see whether there is a presence of AV block or not. So you can have this kind of patient who has a straight line. Now many patients say that this is very high risk, but this is a patient who had a positive tilt table test. This is vasovagal syncope, a conditional syncope which occurs only on standing, and you see this very often on response to stress. This is not high risk. However, if you see the ECG, you will say put in a pacemaker. No, this requires only counseling. So remember the context in which the patient is having this ECG, right? This patient does not require a pacemaker. He needs counseling only. This is tachycardia when we go. The ECG alerts are patient who has a broad complex tachycardia in general have associated cardiac disease and is generally referred to be a VT. So if you have this kind of ECG wherein you have a broad complex regular rhythm and you can see the P waves are more than the QRS complexes, this is a ventricular tachycardia, and ventricular tachycardia is actually a high risk. So refer these patients. They may be associated with structural heart disease. Again, similarly, the incessant runs of tachycardia, these are at high risk. intermittent tachycardia occurring, and this is a normal rhythm, intermittent tachycardia. So incessant tachycardia, broad complex rhythm require. Can you tell me what is this ECG? Who takes a ECG in fibrillation? You need to cardiovert, right? 12 lead ECG in fibrillation is something unheard of. So recognizing the patient is unconscious rather than taking the ECG and start CPR is the most important thing. So ECGs like this should never come onto a stage. Polymorphic ventricular tachycardia, wherein there are short runs of polymorphic, so maybe or may not be associated with long QT syndrome, drug related. What is this ECG? Recognize these patterns. What is this ECG? Patient was referred to us for ventricular tachycardia, but this was artifact only. Because this is normal ECG, you cannot have a normal one lead and abnormal other leads. So recognizing that the patient was normal in this rhythm is very important. Right. This is one thing that we always say, fast, broad and irregular rhythm, WPWAF, fast, broad, irregular, that is FBI. Very fast rhythm, broad rhythm, irregular rhythm is AFWPW, which needs treatment by a EP study RF ablation. Lastly, we go on to this ST-QT interval prolongation with VPCs. So if you have a QT interval prolongation with PVCs, think of electrolyte abnormalities or drug adverse effects or ischemia. These are the three things. Based on history, you can get what the problem is. Even before you get a potassium level, I can say this is hypokalemia. So you can start treatment of hypokalemia immediately. Bradycardia with significant STT changes, hyperkalemia should be thought of. Calcium gluconate immediately can treat the patient, especially in the clinical setting where the patient has been on drugs or with renal dysfunction. Significant STT changes in LVH, which was already taken before. So significant STT changes signify LVH or ischemia, and in presence of QRS voltage which is high can signify hypertension, aortic stenosis or HCM. So refer these patients appropriately. I will not go into these rare abnormalities, but this QT interval, you can see T-wave alternance is very important. Lastly, remember sinus tachycardia with a patient who is hemodynamically unstable. Sinus tachycardia, hemodynamic unstable, think of a significant blood loss or pulmonary embolism, or patient is having acute GI problems. So all these things put together would alert you. So this patient had pulmonary embolism, and the last ECG would be STT changes along with pulses alternance. This was provided to me by a family physician who said something is abnormal. Something is abnormal. Something abnormal itself recognizes that you know what is a normal ECG, and that's very important. Normal ECG, if you recognize and something abnormal is there, refer these patients if they have symptoms. So this was large pericardial effusion tamponade. Okay. Thank you so much.